Good morning, good afternoon, good evening, everyone, and welcome to the third regional symposium of the Global Practice Initiative. As we gather today, I want to acknowledge and honor the shared commitment that has brought us all together, which is a reflection of your dedication to advancing equitable healthcare practices and addressing the upstream social determinants of health. It is your collective passion for collaboration and positive change that makes events like this so impactful. I am Dr. Priya Saravanakumar. I'm joining you all from the University of Technology, Sydney, situated on the ancestral lands of the Gadigal people of the Eora Nation. I pay my respects to the elders, past, present, and emerging. And I also extend this acknowledgement to the traditional custodians of all lands from which our participants and guests are joining today. Today, I want to specially acknowledge the passion and dedication each of you are bringing to this important conversation. This symposium is a powerful opportunity to explore how nurses and healthcare leaders can influence upstream social determinants of health and drive meaningful change in their communities. Together, we'll examine some compelling case studies from across this region that vividly demonstrate that the transformative role of nurses in addressing health disparities. These examples not only highlight the profound impact of nurse-led initiatives, but also will showcase the essential qualities that drive this work, like resilience, strategic advocacy, and visionary leadership. At the heart of our work is the goal of creating evidence-based best practice guidelines that empower nurses globally to address the root cause of health inequities. Today's symposium brings together a remarkable lineup of experts whose work spans a broad range, from lifestyle medicine, care equity, and innovative care models. I'll introduce each of them in detail before their presentations, but let me assure you, we are in for a symposium 2 hour of thought-provoking insights and collaborative learning. It is my privilege to introduce our Global Practice Initiative team, a dedicated group working to advance health equity and address social determinants of health globally. This team, our team, is led by Dr. Natalie Ann Cutler and co-led by Dr. Albie Lawrence Sharp. And our team members are Dr. Deborah Susanna Debono, Distinguished Professor Tracy Levitt-Jones, myself, Priya Saravanakumar, Dr. Mohammad Chutiami, and Professor Michelle Ramsey. And here is a quick overview of today's program. Each session is designed to highlight innovative practices and perspectives in nursing. We have a lineup of expert speakers and thought-provoking discussions that will inspire and empower us to create meaningful change in our fields. So as you can see, we have got a guest lecture by Professor John Stevens, and followed by 3 case study presentations. And then Dr. Cutler will be providing an overview of real-time Delphi. And then there will be an open floor discussion, questions and answers. And we are going to be specifically using Slido. So this is really helpful because you can put in, if you just enter the code or capture this QR code, you will be able to enter into Slido. And if you have any questions for the presenters or panelists, simply head to Slido using the QR code, and you can also upvote the questions. So depending on the number of votes, some questions will be more popular than the others, and we will endeavor to answer all questions, or at least the most popular ones, during the Q&A sessions. And I would also like to, I just wanted to share with you the social media pages to the audience, to our audience, just so that we would like you to stay connected with the global practice initiative throughout these different social media platforms. We've got excuse me, I'm just trying to scroll through the slides. We've got a LinkedIn page, we've got a Facebook page, and a YouTube channel. And please follow us on these channels and stay updated on our projects and the progress that we are continuing to make, access resources, and be part of these important conversations. Now, it is my absolute pleasure to introduce Professor John Stevens, a leader in lifestyle medicine with over 40 years of experience in health practice, teaching, and research. He is a co-founder of the Australasian Society of Lifestyle Medicine and is pioneering shared medical appointments both in Australia and internationally, with a focus on empowering Aboriginal communities. Thank you, Professor Stevens, for joining us and sharing your expertise on the intersection of lifestyle medicine and social determinants of health for nurses. Over to you.
John, you might be on mute.
You're on mute, yeah.
Number one trick. Hey, are you seeing my slides there? Yeah, thank you.
Thank you.
Hey, thanks for the invitation to be here. Fantastic initiative. And I'm so grateful to be part of it, part of this symposium. So, yeah, my name is John Stevens, and I've been a nurse since 1980. And I've also morphed into being a sociologist, I guess. And I'm here today to present to you about lifestyle medicine and some of the initiatives that are available to us that actually promote the social determinants of health in very positive ways. My own acknowledgement of the traditional owners of Australia was a photograph I was allowed to take and show from a time in drought in Australia where fish traps were revealed for the first time since colonisation that were dated to be about 60,000 years of age. And for me, that is absolute acknowledgement that there was somebody here before the colonisers. So likewise, I like to acknowledge the traditional owners, the elders past, present, and emerging. I come from a university called Southern Cross University. I've also, as Priya said, was the co-founder of the Australasian Society of Lifestyle Medicine. And I work at Southern Cross University leading the Lifestyle Medicine Masters program up there. And I want to talk to you a little bit about the society, if you like, because it underpins the sort of activity that me as a nurse and others in healthcare have gone to, have dedicated, if you like, to trying to change the health system from a very linear, non-personalized illness system, if you like, to one of looking at the whole person and wellness. And to do that, one has to take in the social determinants of health. We just can't look at a linear disease model that most of us of my vintage were trained on, and most of our health systems are still based on. This has led to a World Lifestyle Medicine Organization, which some of you might be well aware of at the moment, with 55 nations now with lifestyle medicine organizations involved in that, which is quite a development. So we've come from, the need for this has come out of the idea that most of our healthcare was based on the majority of us being, when we're ill, was due to either trauma or infectious disease. And that was the case for most of the era. And our health systems, if you like, are still sort of built on that largely, both at primary care level and hospital level. But of course, everything's changed. We are now in an era where acute diseases are falling because we've actually got some control over them. Although with the event of COVID, of course, we are now sort of in decline there as well. But through public health initiatives, we largely got on top of the issues of microorganisms. Not entirely, of course, there's still a big role for that. But what came along was the chronic disease momentum. And around about 1980, there's a moment in time where chronic disease seemed to take off in the world. And most of that chronic disease was lifestyle related. That is, we were in control of producing this chronic disease outbreak. And it now accounts for about 80% of all visits to a primary healthcare practitioner, and also roughly those sorts of numbers of people winding up in hospitals, in our hospitals, in the care of nurses. And in the day of the infectious disease and the system that looked after the infectious disease, a short consultation with your doctor, a short visit to an outpatients department meant that, you know, we could linearly treat that disease in a linear way, that we could know that there was a pathogen causing a lot of it, that we knew that because we could take that pathogen out of someone and put it into somebody else, and they would get that disease, and then we could find ways of treating it with antibiotics, or through surgery or other mechanisms to treat it. But with chronic disease, which is now 70 to 80% of the diseases that we are dealing with, there is no one cause. There are lots of determinants. We can't take diabetes out of one person and put it into somebody else. It's a whole of a social event that has brought the rise of these chronic diseases together. And it requires systems thinking, not linear thinking, not disease, cure, out the other side. We now have to think in systems. And a lot of those systems are, in fact, social determinants type systems that we're thinking about. And this, I don't expect you to be examined on this slide when we finish, but it is an example of all the things that go into thinking about what we need to think about in order to sort of get on top of a chronic illness. And out of this kind of systems thinking came the need for an approach, which we now call lifestyle medicine. It had many other names to begin with, but it's coalesced around the world as lifestyle medicine. Whether lifestyle medicine is the right word to determine it, there's lots of debates about that, but nonetheless, that's what we have at the moment. Within lifestyle medicine, we have a systems approach which looks initially at 6 pillars of evidence. So when we are working with people and patients, we're looking at nutrition, physical activity, stress management, sleep, substance abuse or misuse, and healthy relationships with people and the environment. That's the framework with which we work and develop new knowledge and skills and evidence to move forward into this wellness paradigm, if you like. Because so many of us as clinicians are working at the bottom of this waterfall, for want of a metaphor, that we are cleaning up, we are patching up people who are now coming to us with so much of this chronic illness. And our tools have been very, very limited by the systems by which we work in, and possibly the education and skills development that we've had. And it's no one's fault, of course, it's just the way things have evolved. And as clinicians, we know more than just patching people up at the bottom. And so in lifestyle medicine, we were thinking, well, what is it? What is that extra thing? And it's a far more reaching view of health than just patching people up at the bottom. And this slide, if you like, is derived from Rose's causality of hierarchy of causality, and we've adapted it a little bit. And here you can sort of see where most of us work, which is if we're clinicians and nurses and primary healthcare workers and hospital workers, we work down this end, treating these diseases, managing these diseases of lifestyle. Diabetes, for example. And we know there are risk factors involved in this lifestyle medicine, sorry, in these diseases. But as clinicians, we're here treating and managing this, and we don't have a lot of control. We have some, but not much control over what happens at this end. We know, for example, that a major risk factor for diabetes is obesity. But what do we as clinicians, we probably know a lot about how to manage that, but in our day-to-day work, how do we implement this? And how do we sort of work back upstream to do that? And once you start sort of peeling back that onion of upstreamness, it becomes even more interesting, doesn't it? Because obesity, so we ask the question, what's the cause of obesity that leads to diabetes? Well, we know from our science, and we collect a lot of science from a lot of different professions. So one of the beauties of lifestyle medicine is that we are integrating lots of good evidence into practice. And it's not just, it's evidence from lots and lots of disciplines that might have otherwise sat on the shelves because they're good science, but they haven't found ways to integrate it into practice. So we now in lifestyle medicine take that and see how we can put it into practice. And we have great examples or great evidence to say that, well, obesity, we know from the evidence now, is lots of upstream or proximal downstream causes for obesity, probably to do with the way we're eating, the way we're inactive, possibly the way in which, in this case, we might be misusing substances, which is leading to sort of low activity. But certainly we know that gone too far. We know that diabetes related to obesity, we know at least that has diet inactivity in action here. So what's caused the diet and the poor diet and inactivity that leads to obesity, that leads to type 2 diabetes? Well, let's go upstream a little bit further, and it's linked into the evidence that's saying that it's could be about stress, anxiety, depression. It could be about our occupation, our relationships, the poverty in which we work and live. And now we're really hooking into the social determinants, aren't we, about how they are affecting the way we eat and move, and possibly bringing in a lot of other lifestyle factors too, like why we're smoking and using substances, etc., and how that leads to obesity and diabetes. And then we say, well, so why are we stressed? Where's the anxiety coming from? Where's the workplace issues coming from? And then we just keep going upstream till we get to the distal upstream environment. What is that? Well, that's that is the environment in which we live, are born, work and play, if you like, and grow. And it's our social economics, it's our physical and political and economic environment. And it's from here things like, well, if our economy is bad, or if we're embedded in racism, that downstream we increase our stress, our depression, pressure on our relationships, which leads to poor diet, inactivity, poor education, etc., which leads to obesity, which leads to diabetes. So in lifestyle medicine, if you like, we don't just want to work. Yes, we do want to develop the skills and practices that improve this at management level, but we, as a movement of clinicians, want to look at all of this. We want to be advocates for upstream, and we want to do the research and get to know how to integrate all this knowledge of the medial and proximal determinants into our practice. And that's what we do. And that's what we try to do. And so that was how lifestyle medicine was born, if you like, out of a group of clinicians that got together very frustrated with the current situation and wanting to do more with health, to turn it into wellness. And so, interestingly, it was born up around my way in Mullumbimby in northern New South Wales, where we got together for the first meetings. And it's grown from just a gathering of 3 people. Our first conference in 2007 was 40. We now have 1,000 people turn out to our conferences. We have 1,000 members in Australia, of which about 350 or so are nurses. And the remainder are either medical practitioners or allied health. And we offer support and courses and guidance and advocacy and sort of how to integrate lifestyle medicine into practice. And why do we need it? Just in Australia, some of the reasons that we are still very active and possibly seem to be failing is because, for example, in the last 20 years, we're seeing life expectancy at birth stalling. Australia took great pride in the fact that we were rocketing ahead with our life expectancy, but in recent years that's stalled, and it's stalled largely on the basis of lifestyle-related chronic disease, and we're not dealing with it, either preventing it or treating it well. And we can see the top causes of the death. If you look through those, most of those have a preventable and a social determinant issues leading to these being the top causes of death. And these can be worked on at all sorts of levels within that hierarchy that we saw before in previous slide.
Professor Stevens,
yes.
Sorry to say that it's a couple of minutes more, but we can go on. Yeah.
Thank you. And we see the trajectory for good health in Australia has stalled as well. So chronic illness in Australia, I won't go on about it. It's big. Health inequity in Australia is also one of our biggest issues. And again, it's in lifestyle medicine we're trying to deal with. And as you can see, we have a bit of a saying which came out of COVID as well: as a nation, we're not well until we're all well. And we see the biggest health inequity within our First Nations populations, and we see all these terrible health gaps that we're aiming to overcome. And one of the initiatives that I want to speak to you before I go is there's many that were coming out of lifestyle medicine, but one of the ones I'm personally working on and seeing great success in is this notion of shared medical appointments, in that we change the way in which a lot of clinicians already know how to integrate lifestyle into practice, but they don't actually know how to do it. So they have the knowledge, but don't have the way to do it. And what we see is that the conventional way of doing health, if you like, has come from a bygone era that's no longer fit for practice. And so what we're seeing in shared medical appointments is a new way of doing medical or health consultations, where they are done in groups, and they are done in small groups of between 8 and 15 patients. Often there's a clinician, substitute clinician here for a doctor and facilitator. They last about 90 minutes, and they are heavily driven by nurse practice. And I haven't got any time to unpack this, but this is what a shared medical appointment can look like, in that there's the nurse facilitator working with the GP doctor, and in primary care working with these people to deal with their diabetes in ways that wasn't successful doing short one-on-one consultations with GPs. We can do this online. The nurse, practice nurse there is leading this shared medical appointment with the GP online. This is a Aboriginal men's health group doing a shared medical appointment under their house, where they meet and feel very comfortable and safe. Shared medical appointment with a nurse-led practitioner in child health, working with mothers and unsettled babies. Nurses, diabetes educator who's a nurse, and a clinician working with Aboriginal women who are overweight to lose that weight. You can see we're doing this as a group in a gym, in a scenario where they all feel safe, rather than one-on-one consultations where losing weight just wasn't working. In this scenario, this is working. And these are often nurse-driven and nurse-led. We're doing a big project up in East Arnhem Land at the moment in Northern Territory, where we are transforming the way clinic health is done outside as a shared medical appointment, driven by nurses and accompanied by GPs. And lots of evidence to suggest that this works really, really well. And one final slide to look at a specific initiative that was done, which was reversing diabetes in Aboriginal women, where we used CGMs, clinical glucose monitors, an Indigenous diet program that was invented by the participants themselves, embedded in a shared medical appointment program over 8 weeks, and magnificent results showing of 25 women that finished at 18 had significant reductions in their blood glucose. 7 were in complete remission by the end of the program and remained for more than 12 months, no longer requiring medication for their diabetes. This is all based on a nurse-led shared medical appointment with Aboriginal women. And APNA, for example, are really taking on board the notion of lifestyle medicine at the moment, because they see it as a way of bridging the gap with whole person care, and giving the practice nurses, if you like, greater scope, or using their scope in a better way to feel more satisfied with their work, and to have more impact on their client base. I know my time's up, Priya, so I could talk for the entire symposium about all this. So I'm glad you're there.
We could listen to you all day as well, John. This is fascinating stuff.
Okay.
Really, really incredible. Yeah.
I'd love to talk with you all more and unpack the idea of the shared medical appointment, because it's really quite a dynamic, innovative way of working with the social determinants of health and impacting that all the way through to the clinical care. So thank you for your time, and thank you for allowing me to present this, and I'll be here for questions at the end.
Thank you. Thank you very much. That was really, really incredible and very innovative, especially the shared medical appointments, and a totally different way of approaching the issue. And really like the metaphor that you said, which was actually very literal, isn't it? That we are working at the patching things up at the towards the end of the waterfall. Yeah, in every way, that is very true. Thank you very much, Stephens, and I hope we have. I'm pretty sure we'll have many questions towards the end of the symposium.
Thank you,
Thank you,
Priya.
John.
Thank you, everyone.
I'm just going to share my screen now. Yeah. I hope you're able to see my screen now, Natalie. Great,
Yes,
thanks.
thank you.
It is my great pleasure to now introduce Professor Jane Curry, a passionate advocate for healthcare access for priority vulnerable populations. As a nurse practitioner and professor at Queensland University of Technology, Professor Curry's work focuses on improving care for those experiencing homelessness. Today, Professor Curry will present her case study on healthy and home ed, optimizing access to care for people experiencing homelessness. Thank you, Professor Curry, for sharing your expertise and insights. Over to you now.
Oh, wonderful. Thanks, Priya. I'll let me get my tech sorted. How are we going? Have you guys got the full screen there?
Nearly, we can see nearly. You've pressed
Yeah.
the button, but it hasn't come through quite yet.
No?
Just a bit of a lag.
We're still seeing all the
Can you?
Yeah.
slides. Yeah.
What does that do now?
Maybe it's going to a different screen if you're having multiple monitors.
What I might do.
Yeah.
Lovely.
Is that good?
That's great.
Yeah.
As part of the test, isn't it, getting the tech right? Sorry about the delay, everybody. I'll start, if I may, by also acknowledging the traditional custodians of the lands on which we all meet and pay my respect to elders past and present, and extend that respect to Aboriginal and Torres Strait Islander people with us today. So thank you, everyone, for inviting me to talk about the healthy and honed. It's definitely, as Priya said, something that I'm very passionate about. And my background as a registered nurse and now as a nurse practitioner includes practice in the British Army and the Australian Army. So I'm a veteran. And one of the things that actually drew me into practice with people experiencing homelessness was that I had an assumption that lots of people experiencing homelessness would be veterans. And there are a number actually who are veterans in Australia, a lot more in the States. But when I finished my PhD, I started practicing as a nurse practitioner with St Vincent's Homeless Health Service. And it was through that work that I started to have a number of questions from a research perspective around what is vulnerability and how does vulnerability actually impact people's access to care. And from there, we then developed with the team at St Vincent's and academics in other areas as well, a programme of research. And the Healthy and Honed is one of those projects that I wanted to share with you today. And I might talk about a couple of others that I'm working on that may be of interest, but we'll focus mostly on this. Before I get going, I'll just acknowledge that much of the research that I'm going to present to you has been funded by St Vincent's Hospital Sydney and also St Vincent's Hospital Melbourne. So I'm going to sort of start with the end, if you like, and tell you what the Healthy and Honed is. And essentially, it's a model of care that combines three key aspects of care. So the first is identification of homelessness. I thought John's introduction to the social determinants of health was really, really helpful in terms of framing, you know, the impact of things like where we live, what we eat, even who we're socializing with on our health and well-being. And the Healthy in the Home is designed to improve access to care through the emergency department for people experiencing homelessness. And the first step is actually identifying where people live and whether they've got stable housing, or whether they're precariously housed, or whether they're experiencing any level of homelessness. It still beggars belief in my mind that, you know, in public health services, we don't actually actively screen for homelessness. I almost think we should be doing that in schools as well, because the impact of homelessness on people's health is just so profound that, you know, once you know that somebody's precariously housed or homeless, gives you that opportunity then to do a really comprehensive and to try and address some of those issues. So the second component of the Healthy in Home, as you can see there, is to do some sort of an assessment. And where this project began, and I'll explain that in a second, is with actually developing an access to care tool. And that's a comprehensive screening tool that clinicians can use to identify unmet need among people experiencing homelessness. Once those needs are identified and a level of vulnerability quantified, which the tool will do as well, then there's the opportunity for the team, and you know, much of the team in an emergency department is nursing. So some of this would be nurse-led, but doesn't have to be. You know, it's really designed to be a multidisciplinary model of care. The next step is ED care planning. And that can involve timely mobilisation of resources that already exist. So it's not always necessary to have, you know, new resources or people specifically rolled to undertake care for people experiencing homelessness. It can form part of everyday practice. And we've designed over the last 5 years a decision guide that supports the access to care tool that's based on these 5 principles of housing, health, hunger, hygiene, and hello. So, you know, it's not beyond clinicians within the ED to link people to temporary accommodation services and then link people into the community to services that can actually start helping people fill in housing referral forms and the like. Obviously, health is the focus when people go to the emergency department. So addressing both mental health, psychosocial and also physical health needs is important, and that might involve an admission so that then you can gain more collateral information, maybe do some further treatments and assessment, but it also might involve discharge to community services. Then hunger, giving people some food when they come to ED, hygiene, giving them the opportunity to have a wash, maybe change their clothes, which does your skin the world of good, as we all know. And then the hello is follow-up. So maybe organising ways that you can follow people up afterwards, maybe even giving people access to a mobile phone or credit for their phone. So the reason that this came about is because, unfortunately, we know that a lot of people experiencing homelessness actually access the emergency department as often their only point of contact for healthcare. And, you know, we would much prefer, and it would be better for them and also more cost effective for the system as a whole if they could access primary healthcare, but they often don't for many reasons. And stigma is a big one. So unfortunately, they often wait longer and then come into the ED, where the tempo and pace of work is very high. Often the social determinants are not the priority for clinicians. And so in putting this together, we're sort of trying to, best manage the situation and the access to care for people experiencing homelessness when they do approach the ED. So I'll talk a little bit about the access to care tool that we've developed, and then I'm going to share 3 sort of principles that underpin this model of care that sort of speak to other areas of practice, not just the emergency department, and might give some inspiration for ways that nurses in our everyday practice can improve access to care for people, not just in the ED. So as I said before, the starting point for this project was the Homeless Health Access to Care tool. And when I was working with the team at St Vincent's Hospital Sydney in their Homeless Health Service, I started to wonder, you know, is it possible to quantify vulnerability, and how are other people trying to quantify vulnerability? And then could we use that information to maybe prioritise people for access to healthcare, or, you know, prioritise them for service access and so on. So we looked at it and did a couple of scoping reviews and looked at some tools that were available, and we adapted an existing tool called the Vulnerability Index Service Prioritization Decision Assistance Tool, which is one hell of a name, and it's the most commonly used tool in Australia for prioritizing people for housing. And it's shortened to the VI-SPDAT. It's a great tool, but it's huge. It's got 50 items to it. So we gained permission from the original developers of that tool, a team over in Canada led by Ian de Jong, to make the VI-SPDAT into a Diet Coke version that's focused only on health, and you know, with the key to identify unmet need and then prioritize people for access. So what we came up with is this homeless health access to care tool. And you can see on there, the left-hand column's got a number of questions, and they're questions that you would imagine would be there. And each question's been drawn from the results of our scoping reviews and our specialist knowledge in homeless health. Initially, we've got some demographic questions that identify people that might be more at risk of homelessness and also more at risk of comorbidities. Then we've got some questions around where people live. And the key there is to identify primary homelessness, which is people that sleep rough on the streets or sleep in a car or sleep on a train. And then also to identify how long someone's been homeless, because anyone that's homeless for more than 6 months has, grossly impacted health outcomes and is more likely to die prematurely. I think the latest research suggests people experiencing primary homelessness and actually, tertiary and secondary as well, have reduced life expectancy by anywhere up to 20, sometimes up to 30 years in extreme cases, which is alarming to say the least. Then there's questions on service use, understanding that people that have high service use previously will probably continue to have high service use. Then there's some questions on health, physical health, mental health, drug and alcohol use, questions on disability, and then we end with question on intimate partner violence and whether people feel threatened in any way by anyone. And all of that culminates in a score. So the right-hand column you can see has a scoring system. And by working through this tool, we can identify people that are slightly vulnerable, moderately vulnerable, or highly vulnerable. And the definition of vulnerability that we use is a combination of a person's burden of illness and injury combined with their ability to access healthcare and social supports. And then by virtue of that level of vulnerability, we can then identify those unmet needs, plan care to address them, and maybe prioritise people as well. So this is a body of work that started in 2019, and we did, as I said, a couple of scoping reviews, identified the tool we wanted to adapt, used the Delphi process to adapt the tool, and we shrunk it down by half from those 50 items of the bigger tool down to 25 now in our smaller tool. We then did some very pilot psychometrics just to identify internal validity and then having a look at reliability. And we did things like I wrote some fictitious case studies and then asked people to instinctually rate them as high, moderate or low level of vulnerability. And then we used the tool to screen those same case studies just to identify how valid the tool might be in identifying vulnerability and then looking at things like reliability. We also applied the tool to some people experiencing homelessness, living in Tierney House, which is a step-down facility at St Vincent's Hospital in Sydney. And I asked them, were the questions reasonable? Did they, were you confronted by any of them? So on and so forth, because the last thing we want to do through screening is actually do any harm. And we have recently done a feasibility RCT where we've implemented the tool to St Vincent's Hospital, Melbourne, to understand how easy it would be to test the tool on a larger scale. And we found that the tool was acceptable to both the clinicians that were using the tool and also to the people receiving the tool, which was great. It's also given us a lot of data in terms of the demographics of people experiencing homelessness that attend the service there and also their comorbidities. More recently, we've done a cohort study where we applied the tool to people experiencing homelessness at St Vincent's Hospital in Sydney in the ED. And the purpose of that was to identify how many people were actually returning to the ED within 28 days, and what was the difference between people experiencing homelessness and people in stable housing. And we found a significant link between homelessness and representations to the emergency department within 28 days. We also found significant link between trimorbidity, which is presence of a physical ailment, mental health ailment, and also use of alcohol or other drug among people experiencing homelessness. So we're building up, as I said, towards a multi-site, some sort of a step wedge, probably randomized controlled trial in the future, so that we can test the tool more thoroughly. So in terms of sort of broader application, because the research that we've done so far is focused only on the ED, it's really underpinned by 3 key ideas. And the first idea is that inequity isn't always obvious by looking at someone. And that's why we need to screen people actively for things like homelessness. I feel the same about domestic and family violence, which is another area that I've been researching in. The second idea is that health disparities aren't insurmountable, that there are services available to help, and it's really a matter of linking people to them. And that's within all of our remits as health professionals. In my mind, it's linking, as John said so well, the social determinants of health without other assessments, that they're not something separate. They're a fundamental part of who we all are. You know, the conditions that we're born in, that we live in, that we work in, that we play in, so to speak. And so they shouldn't be separated, should be a very holistic approach to care. And then finally, that inequity impacts the way people actually access healthcare, and we need to design services with people rather than for people. So I'll just expand on those ideas very briefly. So we know that inequity isn't always obvious, and the recent census told us...
Excuse me, Professor Cowley, it's 2 more minutes. Sorry for disturbing you.
Right, okay. I'll just whiz forward. So in terms of those 3 points, I think I lost time on faffing around with my screen sharing tonight. Crumbs. There's one thing that I'd really like to share with you before I finish then, which is a tool that I use an awful lot in terms of any research around access to care. And it's called the Levesque Access to Care Framework. And Frederic Levesque is I think he's the chief executive of the ACI, the Agency of Clinical Innovation in New South Wales, which is one of the pillars of New South Wales Health, as you guys know. He has this great definition of access to care, which is that it's the opportunity to identify healthcare needs, seek healthcare services, reach or obtain or use healthcare services, and actually have the need for services fulfilled. And I know I'm running out of time, but I'm just going to pause and I'd like everybody just to think about how hard it can be to do those components. So to actually identify a healthcare need, you've got to come to terms with it yourself, haven't you? I'm sure we've all had things that we go, oh, I will sort that health problem out in the future. But you've got to have a level of health literacy to even know that you've got a problem. Then you've got to know where to seek healthcare. So we hope that most people have got a GP, but we know that they haven't. And a lot of people can't access a GP because of they can't afford co-payments and so forth. And many GPs are now not bulk billing. So that can be really tricky too. Once they know where they're going to go, they've got to get there. So if you're experiencing homelessness, that can be very taxing. If you're experiencing domestic and family violence, which is one of the biggest causes of homelessness in Australia, as we know, that can be really difficult, particularly if you're under a high level of surveillance, or maybe you've got lots of children and you're not sure how you can get there. Then when you get to that health service, you've got to actually engage and use the health service. And you've got to get through the receptionist for a start. Then you might have to sit in a waiting room. That can be really tough if you feel marginalised. And then you've got to engage with the health professional and have your services, actually your needs met. And Levesque has cleverly designed this framework with a top row which reflects the activities that the health service itself does. So things like how approachable is the service, how acceptable, how affordable, and what is the appropriateness of it. And then the foot of the diagram, there's the abilities of people to actually engage with the service. So our ability to perceive a service, seek a service, reach it, pay for it, and engage with it. And this is really important. This is why we need to design services with people rather than for people. Because if you ask people experiencing domestic and family violence, for example, their primary concern is safety. And it's all the domains of safety. It's physical safety for them, emotional and relational safety, it's cultural safety, and engaging with any service. The minute they don't feel safe, they just won't go. So while in Australia we have a world-class health system, and we all know that we do, it really does beg a belief how difficult it is for people to actually engage and use the services available. And as nurses, we've all got that within our power to actually, do these three key things: look at who our population is that we're serving, identify inequity, link people to services, and just know that people's inequity, their marginalisation, really impacts how they're going to use the services. I'll put a sock in it, Priya. I'm sorry, I would have gone over a minute or two there. Thanks very much.
I have to apologize. I think I went in a little bit ahead of time. I'm
Did
very
you?
sorry. Yes, I'm so sorry. I think I got mixed up with the timing. Yeah, but that was, thank you very much, Jane. That was very, I mean, it just highlights the importance of having the social determinants of health at the forefront, isn't it? Yeah, which can be done at all levels by all health practitioners. Thank you very much. And I would greatly appreciate an opportunity, I believe, for the sake of our audience as well, to share the resources through this platform would be really, really useful, I think.
Yep, absolutely. You're more than welcome to have the copy of the presentation. And if anyone would like to reach out and talk more about this work, then I'd be absolutely delighted with that. The idea is for these things to be shared so that we can all be using them. And the more well-equipped we are as nurses to help people. And I really do, you think, as John said, it's, we have to be thinking about the social determinants and how we're planning care, how we're organising care, and making sure, wherever we work, our cities, rural and remote areas, there's people experiencing marginalisation and inequity everywhere. And nurses are the most trusted profession, aren't they? Or at least we fight the paramedics for that every year, and often win. So they do trust us. We've got a big role there. Thanks, Priya.
Thank you very much. Now, I would like to welcome our next presenter. And I would also like to introduce, it's a great pleasure to introduce to you a very skilled nurse clinician and leader, Leanne Papas, and an advocate dedicated to healthcare equity. Leanne has extensive experience addressing the complex health needs of vulnerable populations, including her work with the MICA Project's Street to Home initiative in Brisbane. Today, Leanne will share with her insights from this innovative program, which integrates nursing, support, and advocacy services for individuals experiencing homelessness. Thank you, Leanne, for being with us today.
Thank you for having me. I'm just trying to work out how to share my screen now to that hasn't come out. Oh yeah, there we go. Where did it go?
Lovely, that's perfect.
Thank you. Thanks for having me here today to speak about the social determinants of health. It's such an important topic, and thank you, John, for your presentation, and Jane. It's such a fantastic tool that you introduced there, Jane, and I'm looking forward to seeing it implemented more widely, and also the LEVESQ's tool, which is great to be able to really identify those needs. So my name's Leanne. I'm a clinical nurse lead at MICA Projects, which is a not-for-profit organisation in Brisbane, and I'll be presenting on an integrated nurse and support and advocacy service response in Brisbane. So MICA is a not-for-profit organisation, and we support individuals and families experiencing homelessness, poverty, social exclusion in Brisbane, and focusing on empowering people to improve their quality of life, access to housing, healthcare, and social justice. So the service response was developed as a way of working with people experiencing homelessness to provide an integrated response working with nurse and support and advocacy worker in an assertive outreach way. And the team meets individuals wherever they are. So whether they be in the parks, in streets, in boarding houses or social housing, they're able to outreach, and their first step of engagement is often to use the screening tool, the social determinants of health, which similar to what Jane was talking about in terms of being able to identify the vulnerability of a person and then adapt the service in a way that addresses the social determinants of health to support health and housing outcomes. So the Street to Home nursing service, it's been going for probably 10 or more years, and we've had that experience in leading a nurse-led model of care embedded within a social services team to address the social determinants of health. So the target is hospital avoidance. And we've had a few different models of care that have delivered that cost saving. So the after hours nursing service has been evaluated a few times now, and the most recent one had a look at the service on the nurses are being able to respond to people immediately, providing brief intervention and then linking them in for ongoing care. And that after hours service was able to provide a cost saving of 1.2 million per year in reduced hospital presentations, because we were able to meet those needs in the streets and then link them into primary healthcare for ongoing care, because often when people are experiencing homelessness, we see that bouncing from the streets to crisis service, whether it be ambulance or ED, and then back to the streets, and not quite having those needs met in sort of a holistic way. We have another program as well, which is partnering with hospitals program with the emergency department. So people that might be presenting frequently to the emergency department can be linked in with our hospital partnership team to work with them more intensively in the community and linking them in with primary health care and housing to meet their needs in the community. And then integrated within that is our outreach Hep C screening program. Our nurse practitioner, Kim Rayner, has been leading that program for quite a few years now, because we know there's a higher prevalence of hepatitis C in people that are rough sleeping, and the prevalence rate that she's identified over the last few years is 21% in the homeless population, which is much higher than the general population. We've also been able to include immunisations and syphilis screening. Syphilis just most recently because of those increased numbers we've had in Queensland via a point of care test, and then being able to link them in with supports for that. In Brisbane, we use the Australian Homelessness Vulnerability Triage tool, which has only just recently been adapted. So I just wanted to firstly acknowledge that this screening tool was designed by Ian de Jong, the original tool, the Vulnerability Index tool, which Jane Curry also referred to. And we have recently adapted it in Australia to make it sort of more unique to what Australians' needs are. So the Australian Alliance to End Homelessness led that with people with lived experience and First Nations people to be able to design it, which has been an 18-month process. And it's only just been rolled out now in Brisbane. And also wanting to recognise Roseanne Hegarty, who inspired the Street to Home nursing service in Brisbane, modelled off, not quite modelled off, but similar to what they were running in New York with their street outreach program. So it can quickly assist in providing appropriate or identifying what appropriate housing or healthcare and community services are needed for individuals and families. And Microprojects isn't the only one that does this tool. Other community services across Brisbane and across Australia are using the tool, which feeds into the Brisbane Zero. And then on Friday, all of those community services are able to come together with the Mental Health Service, Queensland Police, Department of Housing, and we're all advocating for those that are the most vulnerable on the street. So it's getting to know people by name and what their needs are and what can best meet their needs. And just having a look at the circle graph down in the bottom corner of the 273 surveys that were done over this time, 215 were in that high acuity classification, so needing more complex needs to support them out of that where they're at, and often co-occurring conditions of mental health, physical health and substance use. It also gives a really good snapshot of health conditions. So it's looking at physical health, mental health, and disability. So looking at the bar graph up in that top corner again, intellectual disability, 76, and physical disability and neurological conditions. And with people that might be sleeping rough and from a lower socioeconomic area, what we often notice is perhaps they don't have evidence of their condition or all of their information in one place, or not able to advocate for their needs or the services. So what our nurses are able to do is bring some of that information together to see if they might be able to access DSP, the disability support pension, or NDIS, so they can get some support services in place that might make them be able to support them in their accommodation once housing is achieved as well. So it's looking at the different domains, including housing and homelessness, social and daily needs, risk and safety, and then health and well-being. And that health and well-being breaks it down to look at healthcare avoidance and exclusion or discrimination due to homelessness, and then brain injury, head trauma, and neurological conditions. So the model of care we use the social determinant screening tool to be able to give us that quick snapshot of vulnerabilities for the individual. And then we work collaboratively with our support and advocacy workers with a housing focused outcome. We've got the establishment and trust and rapport with individuals and families, and I think that's really key in working with vulnerable people, and that takes some time to build up, and it's something that you're always working towards, is building that trust in the service, but then also being able to link them in with other health services and building it slowly over time. There's the provision of an immediate response with people on the streets, parks and homes. So being able to respond when people are in crisis is quite key, and having that flexibility in the service to be able to do that. And then to be able to link them in with health assessments and referrals into primary healthcare, because we know if they're better linked in primary healthcare, it can avoid some of those crisis presentations. And then engagement in proactive early interventions for preventative healthcare, which is some of that screening that we've been able to bring in. So some of the challenges that we've seen in the Street to Home outreach team is the reluctance to seek hospital care due to negative experiences or mistrust or stigma. And the way the outreach nurses have been able to overcome this is building trust. And we've definitely seen when we haven't got that trust, like from working with the participant for over some time, that sometimes we don't always have as much success in getting them into the healthcare that they need. So it's really key to build that trust. There's advocacy for individuals by engaging hospital staff to ensure that there is non-judgmental, trauma-informed care. So often we might need to walk them through the service or take them to the ED and stay there until they're able to be admitted, and really make sure that the staff that you're handing over to are aware of what the person's situation is, and perhaps if there are certain triggers that you can help to prevent for their admission to make it more successful. And then providing support to overcome the social determinants of health, and it bridges that gap between individuals and the healthcare system. So lessons to guide others is working from that trauma-informed, person-centered approach, advocacy and collaboration with other organisations and community services to ensure that they're linked in, and then flexibility and persistence. I think our CEO, Karen Walsh, is really innovative in allowing us to work in that flexible way and adapting services to what's really needed by the population. And it's key to the way we are work to be able to make it more flexible. And then persistence. Often we get a lot of no's, but we just are gently persisted in going back until we're able to link them into what they need. So reflections on practice. The screening tool has been brilliant because all the different organisations are able to feed in that de-identified data, which gives trends and highlights populations. And I know from a system perspective, it's really great from a point of advocacy as well. And when you have a look at that data and reflect on the needs, the dental is so high with people living on the streets, and then we're able to advocate to our local practice that we work with has dental services. So being able to have that in the one place, because you know that's going to support the person's needs a little bit better when they can do a few things at the one location and they're not having to navigate that another system. It also reinforces the importance of trauma-informed care, person-centred approach, and highlights the role of trust as a foundation for meaningful engagement. And most importantly, that ability to respond flexibly dependent on the individual's needs. And even flexible for each engagement. Often you might be going to see a person to take them to an appointment or this, but another crisis might have popped up. So we're able to sort of shift the focus for the day depending on what the person's need is. The reluctance to access mainstream services due to past negative experiences, stigma, low health literacy, and complexity of health systems and competing priorities, and building trust to foster that equitable healthcare access. So just to conclude, the NES-led interventions integrated within the social model has focused working collaboratively, building trust, advocating for trauma-informed care, and facilitating connections between participants and healthcare providers to support outcomes. Thank you for listening. That's some of the models of care that we have available on our microprojects webpage, which gives a little bit more details on the different models. So I'll just stop the share there.
Thank you very much, Leanne. That was very, very informative, and what a great job. Yeah, so that's what a great initiative, actually. Yeah. And I'm looking forward to we've got the colleagues monitoring the Slido, and I bet we are having plenty of questions coming our way. Now, let me just share my screen again. Natalie, can you see my, share? Yeah, okay.
Yes, yeah.
Great. Now we are coming to the third and the final case study presentation. It is my pleasure to introduce Naseef Mahmood, a final year medical student from Uttara Adhunik Medical College and Hospital in Bangladesh. Naseef has a passion for advancing global healthcare, particularly in addressing public health challenges and enhancing healthcare systems. Today, he will share with us lessons from his cross-sectional study and implications for nursing practice and leadership. Thank you, Naseef, for joining us and contributing your valuable perspectives.
Thank you so much. Thank you so much. Thank you.
Naseef, are you able to share your screen?
Yes. It is shared. Hello.
Not
No,
yet. Not yet.
Sorry.
I wonder if we could share the slides for Naseef, and then perhaps Naseef could speak to them and let us know if he'd like us to transition them. Would that be easier, Naseef?
Yes, ma'am. Thank you.
Who's got the slides? Natalie, have you got the slides, or with Samantika? Apologies, everyone.
I
When we are
have
trying to figure out.
I have the slides. I'll share them now.
Great. Thanks, Sally.
Sorry, ma'am. My problem is my device now.
That's all right.
Sorry.
So Nassif, just let me know when you'd like me to change to the next slide.
Okay. Thank you so much. Morning, everyone. It's a pleasure to have be here today among such dedicated professionals. So myself, I'm Nasif Mahmood. I'm from Uttar Adhunik Medical College and Hospital, Bangladesh, and my insight from my case study, which mainly I focus the implications for nursing practice and leadership in response to MPOX, lessons from a cross-sectional study in Bangladesh. I selected this case from my curiosity when there's suspected case I found in Bangladesh, June 2024. Then I started this case study amongst different health professionals like nursing students, medical professionals, dental students, and all other health care professionals in Bangladesh. And I have collected totals 100 data and including 43% are nursing students. So I today basically I'm focusing on the nursing led groups and nursing subgroups in these conversations and nursing case. So I have collected 43 data and and uh, so sorry.
Next slide.
Yes. So I collected 43 data. I collected for 43 data. The study contents and objectives I mainly focused on the preparedness, and knowledge gap and practical challenges during infectious outbreak like mpox. And their objectives is understand their preparedness, knowledge gap, and practical challenges during infectious disease outbreak. Um, the nursing of the future combat for this combating infectious disease and in the knowledge levels. Can you please? In this case study, we at the nursing student, they have the knowledge about infectious disease. The nursing student, in my case study, I see that distribution of primary information source. The most of the nursing students, all also knows about the heard about the mpox virus, and the 50% of those get the information from social media, news media, and other sources. So there is a gap that the curriculums on the academic source they don't have not much information about mpox viruses. So there's a between the formal training. Also, in my case study, I see that 30% of the identified mpox as zoonotic disease. So the maximum 70% they don't hear that this is a zoonotic disease or a communicables or an environmental kinds of disease they don't know, and 40% are receiving formal training also. So there is a gap that they don't have receiving a formal trainings in infectious disease like mpox. Can you share the second slide on? Thank you so much. Prevent it, and then we come the nursing student equipped prevent about infectious disease. In this case, I mainly highlighted the hand hygiene practice nursing and preferred preventive measures for mpox. I see that 60% of the nursing students are they practice hand hygiene like they were, and after handling animals, the mpox can transmit it through it is a zoonotic disease and then transmitted from animals to humans so easily. So the hand washing by hand hygiene is must in these cases. And 20% occasionally follow hand hygiene protocols. And we can see that 25% of the nursing students use a personal protective equipment, and 30% they don't rarely or never use this personal protective equipment. And then we go to the preventative measures. 40%, I see that 40% of the nursing students avoid contact with suspected cases, and 30% prioritize wearing gloves and masks. We can say that there is a we can say that there is a chances that they have a lack of knowledges, or they have don't any trainings, or any inadequate supplies. So we can also mention that there is inadequate supplies of personal protective equipment, or um, they have a lack of knowledge in this regards. I can see that. See the next slide. In my next slide, I have seen that there is a challenges nursing student. What barrier do nursing student encounters in my country like Bangladesh? So there's I say that when I go to the nursing institutions with my colleagues, I've mentioned that my nursing colleagues are not available to here today due to some examinations in their institution. Um, when I go to the nursing institutions along with them, I see that when I ask some of them on colleagues and nursing students, and they face some barriers in regarding in handling the infectious disease like mpox. So there's they said that they have inadequate training, they have resource training, and misinformation risk. So in adequate training, they say that there is a limited exposure outbreaks, specific protocol in their educations, and this infectious disease management in our country like Bangladesh, and resources constant insufficient access. There in my country, like Bangladesh, we have insufficient access to PPE, like gloves, masks, during clinical rotation. So the nursing student cannot combat in this, and they have due to this insufficient access, so that this transmitted the infectious disease so easily from one to another. So the other thing is the lack of institutional system to ensure adequate supplies during outbreak. And then there's a misinformation risk, there's over reliance on social media and non-academic. So we highlight that there's the academic curricula, there's a we must have the knowledge and must have more information about infectious disease and how to handle them, how they transmitted from one another, from animal to males. And for this, the well-developed country like Australia, we wanted also in our country that we we want sufficient access PPE for our institution, for our nursing colleagues, so that they can handle all these cases. So the implications, these challenges reduce student readiness to manage infectious disease outbreak effectively. Can you share the slide? Thank you so much. So the upstream interventions for improvement, what can be done to address the challenges? What can be done? We can policy reform in nursing education, resource planning, and protocol development and dissemination. So in policy reform in nursing student, we can say that the introduce mandatory courses focus on outbreak preparedness and infectious disease management, incorporate to hand-on training, the simulations, the mock outbreak drills. In the resource planning, we can say that the established institutional policies and equitable distributions PPE to all nursing students. and the protocol development and dissemination. We should create a clear evidence-based guidelines for nursing students on infectious disease management, disseminate materials through educational platform and workshops. Can you share the sixth slide for me? So in this slide, we can see that the nursing leadership in infectious disease prevention. So the empowering the nursing student to lead the way, that we mainly focus in this case study, that leadership development, advocacy roles and community engagement. So the nursing student leadership development is so much important in this case. Training nursing student to lead the infectious control teams during outbreaks, well equipped, well maintained, and the nursing students should train well so that they can handle and combating the infectious disease prevention outbreak in our country like Bangladesh. And we can see the advocacy role, advocacy for health policies, and that's the portability and robust the and dispels misinformation. Can you next slide for me? Thank you so much. Then in this case, the first conclusions. The conclusions and the conclusion part. The previous slide.
Okay, sorry. Hang on.
So the conclusions part and call to an actions. The lesson learned that not hinders nursing students preparedness for infectious disease outbreaks. For this is a recommendation for the educators that the outbreaks specific courses solution into nursing curriculum. So the nursing curriculum must be enriched with knowledge, enriched with much knowledge with infectious disease control, outbreak, and how they handling. And for institutions ensures constant access to PPE and resources for students. So there is a adequate supplies for PPE like gloves, sanitizers, masks, etc. For the policymakers, the promote nursing leadership roles in public health initiatives. So what is the call to action? The collaboration between educator, policymaker, and healthcare leaders is essential to prepare future nurses to combat global health challenges. Thank you all for your attention. I look forward to your questions, and sorry for the I have a technical issues in my device, so I apologize for that. And thank you so much for hearing me, and thank you so much.
Thank you very much, Nasif. That was an interesting
so much.
presentation. I'm sure we'll have
Thank you.
questions regarding
you
the
so much.
support given to nursing students when it comes to
Thank you so
treating
much.
or preventing infectious diseases.
Thank you so much.
Now, may I please encourage everyone, especially the audience, to put in your questions through Slido. It is also share the code again. Yeah, so keep your questions coming, and yeah, I would like to introduce our lead researcher for the Global Initiative team, Dr. Cutler. Dr. Natalie Cutler is a senior lecturer at the University of Technology, Sydney, and a champion for global health initiatives. With a strong focus on community-led mental health and addressing social determinants of health, she leads innovative research and educational programs that foster cross-cultural collaboration. Today, Dr. Cutler will be presenting an overview of the real-time Delphi study that is used in this project. Thank you, Dr. Cutler, for your leadership and dedication. Over to you.
Thank you so much, Priya. Hi, everybody. And this is the final symposium of our series, and the series of symposia is part of the Global Practice Initiative that has been funded by the Worldwide Universities Network. And the Worldwide Universities Network, our partners in that network are collaborators with this project, and they include some of the universities that you see here, but we also have collaborators beyond the WUN. So we're very proud to be associated with this esteemed group, and the work that's being done and the learning that we're all developing through our symposia has been really something. And today's presentations are a wonderful example of that. And so as part of, or as an extension of these symposia, our, as you know, we're focusing on the upstream social determinants of health. And as John set us up so well at the beginning of this symposium, to look at what actually do we mean by the upstream social determinants. And we're talking, very much about the high level policies, laws, regulations, and the things that I loved how John said the causes of the causes of the causes. That's where we believe that nurses have the potential to have an influence as the largest health workforce in the world, to really have an impact downstream and on the health outcomes and the health experiences of people. So in relation to that, we're looking at a project which is exploring the critical role of nurses in addressing the upstream social determinants of health and advancing equitable healthcare practices globally. And our aim is to bring together experts from nursing and related health fields to reach a consensus on best practice guidelines to empower nurses' capacity to influence at the upstream social determinants level. And to do that, we propose to undertake a real-time Delphi study to establish the consensus. And participants, if you're not familiar with a real-time Delphi, it's a little bit different to a traditional Delphi where you might meet over
Apologies, Natalie. We're unable to hear you. I'm not sure whether that's the case with everyone.
To bring people together in an online survey portal. So the questions and the iterative process is conducted completely online, and the panel members can enter that portal any number of times to update their responses, to see what other people's responses have been. And in that regard, it's a very much a transparent and iterative and dynamic process. So we're very excited to be undertaking this project, and as I say, to develop the evidence-based guidelines for best practice and bridge the gap ideally between theoretical knowledge and real-world nursing practice. So if you're interested in knowing more about the study that we're going to be undertaking, and if you would like to be considered as a member of the expert panel, please reach out and contact me, and we'll be circulating the survey soon. So if you do have an interest, please reach out and let us know. So that's it from me. Thank you.
Thank you. Thank you, Natalie. Now I will move on to introducing our next very important member in our group, the co-lead of this project, the Global Practice Initiative, Dr. Sharp. Dr. Albie Sharp is a highly experienced academic and researcher, currently serving as a course director for the Bachelor of Public Health at University of Technology, Sydney. With expertise in public health, non-communicable disease prevention, and health promotion, Dr. Sharp brings a wealth of knowledge to our work. And together with Dr. Cutler, Dr. Sharp will be moderating the open floor discussion that we're going to have. But before that, may I please ask everyone to smile for a group picture? And may I please request a couple of members from our team, either Natalie or Samantika or LB, to please take the picture. I'm going to stop sharing.
Could we ask everybody to turn on their cameras? and
Yes.
we'll get a group photo of everyone that's attended.
We don't want
today.
anyone hiding behind closed cameras.
Do you want me to take it, Albie, or you're good?
At the moment I've only got the main speaker, so I'm on the wrong setting clearly.
Please, as many people taking will be beneficial.
Yeah,
Because thanks, Deb.
Look at those lovely faces. I think this is my favourite part. Hi, everybody. Wow. So 1, 2, 3. Snap. Lovely.
Thank you.
Thank you, everyone.
Okay, so now we are going to the next interesting part of this symposium. Yeah, before that, yeah, I've got the Slido, the code as well here for people to keep putting their questions in, and also to vote the questions that they like, they prefer. That way, we'll find out which is most popular and we'll endeavor to answer all of them. I think we do have time now. Yeah, so over to Albie and Natalie.
All right. Well, thank you, everybody. Firstly, thank you to our magnificent presenters. I found all of the presentations today to be really informative. It was great to get those two different perspectives of the way nurses can address the issues of homelessness in different communities. I thought that was and the tools that they've both developed. I also like to thank John for his really informative presentation of lifestyle medicine. This was an area that we were not very familiar with when we started this project, and this is something that we are learning about and engaging with as we go forward. So, and finally, also thank you to Nassif. I was really pleased to include this presentation because I think infectious disease isn't something we've engaged with very
Thank
much
you
in this
so much.
series.
Thank you.
So, you're very welcome. Yeah, it's just not an area that we've been able to engage with. So I think bringing that into the conversation and the settings that Nassif is working in are really important as well. Natalie, did you want to ask a question, or shall I go ahead, or how should we do this?
Well, you go first, and then we can maybe tag team.
Sure. So we've put the links in the chat for anybody. And of course, you can click on the slide here as well if you wanted to ask a question. And if you don't have a question, please go online and still upvote the questions that you can see there that you think might be interesting and that you would like an answer on as well. But I might just start off with asking Professor John some of those questions that we got from that first presentation. So we had a couple of people very interested in your map of the social determinants of health, and there was a vertical term called metaflammation. Could you explain what that is and how it relates to lifestyle medicine?
Thanks, Albie. Good question and good pickup. Whoever saw that. If you like, it's almost like our germ. Well done, Natalie. It's almost like our germ theory, if you like, of lifestyle medicine, of chronic disease. In a germ theory being that, we know a germ causes an infection. We don't have the same cause and effects for chronic disease. But what the research is showing, largely from a guy called Hürtem Schlegel from Turkey, is that the majority of chronic diseases have their origins in metabolic inflammation. Somewhere in the process of stress response or trauma response or response in our body, we produce a very low-lying, hard to detect inflammation, but it tends to at some point express itself later in life as a chronic disease. And working backwards, most chronic diseases, one of the markers of a chronic disease is that most people have raised systemic inflammation. So if you wanted to say one thing that we try to achieve in lifestyle medicine is we want to reduce inflammation, and that can be through diet, stress, exercise, stress relief, exercise, better sleep, all the things, all that framework we talk about, and all that effect on the social determinants is actually plays an effect on inflammation, which then leads on to chronic illness.
Sure. Okay. Can I just follow up with a couple, specifically my question? So I'm being a bit greedy here. I noticed that you're teaching a master's program in lifestyle medicine, and I'd be really interested to know what the outcomes are for your students in terms of that translation to practice, which is one of our key questions with this project.
Well, we have reports from our graduates that it does indeed help them translate a lot of the knowledge they already had, and it improves the knowledge that they had as well, and translates it into practice. And just the framework in itself, the 6 pillars, for example, gives a lot of practitioners a very obvious scope to assess patients when they come in through consultations or at the bedside, much like the other tools others spoke about. The notion of using shared medical appointments, sometimes known as group consultations, and lots of other names by which it's known by. That's probably a little bit of a revolution in terms of healthcare, in terms of it really does give the time necessary to integrate a lot of that knowledge into practice, because shared medical appointment will take 90 minutes. Everyone gets their consultation with whoever the clinician is. And then hearing what other people have to say, they learn from each other as well as the clinicians. And the clinicians are able to use their knowledge and skills in ways that they can't in those short consultations, or restricted by the bedside systems of a hospital. And so, yeah, I hope that answers the question.
So does that I just follow up on that. So is those shared sessions, are they for people with similar kinds of symptoms, such as, for example, diabetes or something like that, or are they cover a kind of broad spectrum of different conditions?
It takes a bit of unpacking, but we say if you've seen one shared medical appointment, you've only seen one, because they're all different. But generally, when you're starting off doing them, we tend to try and make them homogenous groups, people with something similar in common: diabetes, chronic pain, mental illnesses, etc. And that helps the group bond and focuses a bit of the attention. But it doesn't mean that the what happens in the group doesn't sort of go in lots of different directions. Yeah, but they're all quite different. But yes, we do try to work with people who have similar conditions. That seems to be the easiest.
All right, I might pass over to Natalie for another set of
Thank
questions
you.
now.
Okay, thanks very much, Albie. And I just wanted to flag, I wasn't aware of it until just a moment ago, that our last presenter, Nassif, that was his first ever presentation. So just wanted to congratulate him, and yeah, he's crossed that threshold. Well done, Nassif. To a special audience. Pleasure. Okay, so my question, and I'm going to be greedy like Albie. I've got 2 questions lined up. So these are from the group. So Professor Curry, could we ask what definition is used for homelessness in your work?
Oh, that is such a good question, actually, because there's no nationally agreed definition of homelessness. And I tend to use the one from the AIHW, so the Australian Institute of Health and Welfare, and I can't remember what it is off the top of my head, but it's something around having, Leanne might know better than I do. I'm going to throw it to you, Leanne. But it's something about not having an appropriate dwelling or an insufficient dwelling. But it's such a great question because it affects all of the data, not having a nationally agreed definition. And in my mind, I generally think of primary homelessness, and this is what we've been using in the tool, is people that are sleeping rough on the streets, sleeping in a car, and sleeping on a train or sleeping on a train. And then secondary homelessness, I tend to think of couch surfing, staying in overcrowded dwellings, staying temporarily with a friend, that sort of thing. And tertiary homelessness to very temporary accommodation, so maybe staying in a boarding house under a short-term tenancy or something like that. There's also if you've ever seen any of Paul Flatto's work, I think he has a 4th level, which is when people are staying in an institution, so when they're in hospital long-term or whether they're in prison or something like that. But it is really important that if you're doing any work in this field, because there's so many different definitions, you have to identify which one you're working with so that everybody can appreciate the different nuances of that. And I'll just add on, Natalie, if you don't mind me, you'll never stop me talking when you ask me a question, by the way, is that sleeping is in the minority. So when we think about how visible homelessness is, you know, the census data teaches us that it's actually only 6 or 7% of people are rough sleeping. They're generally more obvious, what, you know, to look at. And I don't want to stereotype anyone, but they often have a disheveled appearance, perhaps, or have belongings with them that give you a sense they don't have somewhere safe to be. But really, the bigger group is people who are sleeping with friends temporarily, couch surfing, overcrowded dwellings, in boarding houses, motels, and it's in the research I've done, that's a group that reattends emergency a lot, and so they're a group really that as nurses, just screening for homelessness is so important, and you can do it quite simply. A lot of us are afraid of doing things like that, afraid of asking about domestic and family violence too, because you know, as the research shows, our biggest fear is, what if someone says, yes, I am experiencing homelessness, what am I going to do then? I've got to try and find a way of helping. And the same with domestic and family violence. But as I hope I've given hope, there are lots of services available. Leanne and the team at Micah Projects are fabulous. And that's just one example of a specialist homeless service that exists here in Brisbane. But there's many more that you can find. So I went the long way around, of course I did. But there you go, Natalie.
Thank you. Thank you. And I will tuck the second question on the back of that, which is just, have nurses been involved in advocating for homeless clients to access housing or non-health services, and how far do nurses go in providing support?
Yeah, that'd be a good question for Leanne as well. I've worked with Micah Projects in Brisbane as a nurse practitioner, and my primary role there was providing healthcare and also addressing unmet needs. And one of those needs is housing. And nurses go a long way through that process. They often work then with the social work team, depending on what services are available within the team you're working, and obviously that affects your scope of practice and when is the point that you need to hand that over maybe to a housing organisation or the Department of Housing. But it's very simple actually to fill in and support people to fill in the housing referral forms, and I've done that a number of times, and I'm sure Leanne has as well, helped fill those forms in. So I think there is a big role for nurses, but I think probably, Leanne, you're better placed to answer that question than I am.
Yeah, I think within our team, because we work with the social workers, and that makes a bigger difference, because when people are applying for housing, they often require a confidential medical record, which can sometimes be another barrier for people, because then you need to make a doctor's appointment. We need to find them. We need to get them to the appointment. You need to have a few appointments with that doctor before we get all their medical information together, which, when there's a lot of crisis going on, sometimes that's a bit difficult. But working closely with our Department of Housing in Queensland, they will accept letters from us. So if we're able to collate that information for them and then advocate for urgent housing because of their health needs, that makes it a lot quicker, the process, and we can get quicker outcomes for people working closely with the Department of Housing and with our support workers within the team for people that have got significant health issues why they're experiencing homelessness. And that would be many years of work of Micah Projects and our CEO working closely with the Department of Housing to have that recognised as an organisational response.
Thank you. Thanks very much. I'll hand over back to Albie.
All right, I might just move on to Nassif for a minute and ask him 2 questions that we've got on the Slido as well. So Nassif, firstly, can nurses play a role in the prevention of MPOX? You talked a lot about the clinical setting and how they might work within that in terms of dealing with patients and protecting themselves and others. But what about the preventive activities that nurses might be involved with? particularly in terms of the social determinants of infection and care?
Uh, in my study, I focused mainly the personal protective equipment to handling cases during the patient camp and during the handling the suspected cases. So there is adequate supplies of personal protective equipment would be here in the poor country like Bangladesh actually. So we don't insufficient collect of personal protective equipment like gloves, sanitizers, and masks, etc. The nursing curriculum in our countries is must need to be more developed because the nursing are the front line monkeypox or any other infectious disease. So the nursing curriculum must be included more and more information about how to handling the infectious disease and how can be prevented this infectious disease and how they prepare themselves from handling the cases. So the information and the knowledge must be more and more in their curriculum so that they can combat this outbreak of this infectious disease like monkeypox. Thank you.
Okay, thank you. That's a very interesting answer. And I also wanted to follow up and ask you what kind of like leadership training nurses receive within the Bangladesh nurse and medical training system, and then like leadership within the health system as well. So what opportunities are there for nurses to develop leadership skills?
In my countries, the nursing leadership is so many importance. In my countries. I see that there's so many programs are held, but the nursing students also participate there. But due to the information gap, they cannot attend or attend the training or attend some lack of trainings, lack of institutional support. They don't give actually for the nursing students for infectious disease controls like trainings and others. etc. We have lack of trainings in capacity in our country for nursing students, and we have to improve it day to day, day by day in our country to combat the infection disease prevention like monkeypox.
Yeah, interesting. Yeah, I suppose like when you're talking about developing leadership, you need the leadership to develop that leadership. So it's a kind of chicken and egg process of slowly developing that skill and capacity as you go. Yeah. Natalie, sorry, I cut you off then.
No, that's okay. I do understand Nassif had invited a colleague to join, a nursing colleague to join him, but unfortunately she also had another presentation today. Otherwise she would have also been here to present with him. So I have a question for Professor Curry, and this is the question is, considering Leanne, don't look too happy, there's more for you too. Considering the stigma related to homelessness, have you encountered this as a barrier to healthcare professionals implementing the tool in emergency departments?
Yeah, it's a really interesting question, the stigma thing. In terms of people implementing the tool, we're in the feasibility study that we did at St Vincent's in Melbourne. This wasn't a problem in that department in terms of the health professionals' willingness to want to implement the tool. And the St Vincent's as a suite of hospitals, the Sydney Hospital has a homeless health service, and even within the St Vincent's Hospital in Melbourne ED, they have people employed there that have a specialist role in supporting people experiencing marginalisation. So you could say that they're sympathetic hospitals anyway to apply something like this in. So I haven't experienced that yet. But I have experienced in my own practice a stigma, you know, when Leanne said in her talk about the Street to Home team, when I was working with that team as a nurse practitioner, and I would take people into the ED, and even as a nurse practitioner, the registered nurses would, depending on where I went, sometimes ignore me, you know, as well as the patient. And I know there's a real problem in nursing around trying to embed even trauma-informed practice, you know, get people to consider the social determinants of health. And I'm not always sure why we don't do it as readily as I think we should, but there is a real gap between what we teach and then what people do in clinical practice. For me, it boils down to kindness, actually, that, you know, if people could be more kind in their practice, wherever they're practicing, then people would be more willing to share with them. And, you know, nurses are the most trusted profession, and we're really proud of that. But I think we need to work harder to continually earn that rating, because, you know, as I say, even from my own experience working with vulnerable people and trying to assist them into mainstream services, it can be really tough. And I'm not surprised they don't go, because I wouldn't want to go if I was treated like that a lot of the time. So I think we've got I love what you guys are doing with your global initiative, because I search for ways in my own mind to think, how can we influence this and what can we do? Because it does seem to be very personality driven. So no stigma yet about implementing the tool, but that may come. But I think that the bigger challenge is how we get all of us as nurses to really embrace this, given that, you know, have very stressful workloads. And I think that's the first thing people might say in an environment like ED: well, I don't have time to. And I kind of think it goes back to that thing of, if not us, who? If not now, when? You know, because people need help, and we have the help available, and particularly in hospital settings, all the specialties that are there and all the people that could help people. It's just, you know, sat right on the doorstep. It's very different from community practice, where it can be very difficult to access specialist knowledge and expertise, but in hospitals it's all there. So please help. If anybody else is it working in ED or, you know, anywhere else, please help people. It's it really is the last resort when people get to the hospital. Thanks.
Yeah, and the concept of scope of practice was mentioned earlier, and that capacity for nurses to work to their full scope of practice, not just that sort of one delivery of care, and that social consciousness that and the power that our collective numbers have is really unharnessed as yet, which is sort of what is underpinning this project. Now, here's a question for Leanne. So with the Olympics coming to Brisbane soon-ish, in the next 8 or so years, how will people experiencing homelessness be supported during that period? Because I know that that is a group that are often displaced because of the influx of more people and so on. So do you have any thoughts, or is there preparation underway already?
Goodness, no. I mean, we look at it as an opportunity, really, isn't it? Because it's an opportunity for more housing. And Mike is a 24-hour service, 7 days a week. So, like, we would be there supporting them no matter what. But we haven't been in talks, or not that I'm aware of anyway, of what would happen. But it could certainly be an opportunity for us here in Brisbane.
Okay, thank you. I'll hand back to Albie now.
We might just open up the floor for comments and thoughts from anybody on any of the issues and any of the approaches that we've heard today. That includes our guest speakers, but also anybody else in the audience today. You can put up your hand, or if nobody's speaking, maybe just start speaking. Okay, I'll speak. So I was very interested, John. I just got in before you there, I think. Very interested in the experiences of working with the homeless, and I was reminded, because I had a very not a very deep or long-term association with the Went West Youth Health Service, and one of the pilot programs they employed was to get a health navigator to help mainly secondary homeless youth to stop using the ED and get them registered with a GP so that their health needs could be met. And one of the really interesting stories that was told was that the nurse who was the health navigator located this young man who was deeply concerned about kittens that this cat that he'd been looking after had just given birth to. And so she spent the entire day at the vet addressing the health needs of these kittens as a precursor to addressing his health needs. And that was her way of building that connection with him and then starting to work on all the other things. And I just remember her saying that she was so totally astonished by the fact that here she was a nurse and she was spending the day at the vet as a way of getting that a really important care process going. So yeah, I just when you were talking about that, I just had that resonance of that experience as well. Sorry, I'll pass over to John.
I guess I just wanted to pass on some of my experiences recently in rural Northern Territory, where homelessness is probably the leading cause of it's the path to most of the illnesses that we see. In the communities that we're working in at the moment, we're seeing houses with 20 to 40 people living in them, where there's no food security because you can't shop in advance and store food because everyone eats it, where there's children aren't getting regular sleep patterns, there's a lot of stress in the house, there's a lot of poverty in the house. And to go into those communities and suggest for a moment that you can help people with diabetes is kind of obscene, because they can't do any of that. They can't eat well, move well. You know, that's the obvious thing that we ask people to do is the solution to diabetes, you know. When they don't even have a roof over their head to sort of get that stability to even go that way. So a lot of the work we have to do in managing diabetes is work right back upstream to try and work on housing and connections and family relationships, etc. So it's where I'm working at the moment. It's probably the issue, and there's a whole lot of other determinants as to why the housing is so poor and why that housing issue is such a big issue, and that's beyond the scope of, I guess, nurses, etc. I'd also just like to say it's so wonderful to know that there's a global initiative around this. Can I say from a nursing perspective, and in lifestyle medicine, and a shout out to my colleague Sam Semendiga, that, you know, having established the World Lifestyle Medicine Organization and bringing people from all over the world with such, and it's surprising how similar and how similar the concerns are across the world. When you find yourself united in like a family of people with a common cause and desire to change, it makes makes your life a lot easier and makes you feel part of something. And it's really quite special. So what you're doing here it is really special. I just wanted to say that. Thank you.
Thank you so much, John, and thank you all for, you know, participating and being part of this conversation. It is the beginning of that groundswell, I really think. Now I think that we might hand back to our MC Priya to bring our event to a nice close without any need to hasten and rush. So can I hand back to you, Priya, please?
Yeah, we have time for a couple more questions.
Okay.
Given
great.
that it is 7 minutes to 3. Yeah, but I actually put up my hand because I had a question to share.
Go ahead.
That was, was listening to John and Jane and Leanne, and given the prevalence of homelessness and the number of vulnerable people with especially the social determinants of health being a huge issue. One thing is, I want to make an observation. John, you shared about the shared medical appointment initiative, which I thought was incredible. But then I was interested to see why only 1,000 membership? Why only so much? Why isn't it, like everybody should be, joining this group, and that was one thought. And the other observation that I was thought that came to me is can that be extended to student populations, across the health professions? Because I think that would be a great way to show them what they can do and what they can achieve, and also give them that rewarding experience. And finally, I was also thinking it's not just the health professionals, but we should be involving, partnering with, financial advisors, people who provide non-health, medical services as well, because they also play equally a very large role in impacting on social determinants of health, isn't it? So should be working with the council, working with NGOs and other groups of people. So what is the way out? And I'm sure Jane, Leanne, and John, you would have faced a lot of challenges even getting your programs, your initiatives to to this level where it is now compared to when you started. So could you share with us some challenges that you had, or what do you think is the way forward? Thank you.
Crumbs, it's a big question for us, isn't it? And
apologies.
As you
I'd say what we have in common is flat foreheads from bashing our heads against brick walls for very long periods of time.
maybe,
Possibly.
yeah, and maybe a commitment to optimism, John, Leanne. As you were talking, Priya, the councils actually are generally very involved in homelessness, definitely in the work. You mentioned the Cooling Hub at the beginning, Natalie, and the City of Sydney Council are actually a partner within that. And I didn't have too much to do with Brisbane Council in my role with Micah, but Leanne, you speak to them regularly, don't you? And they are hand in glove, but that's the case for specialist homeless services because they're based in the community. And if anyone doesn't know, specialist homeless services are government funded to a degree, and then they rely on philanthropy and charitable donations to boost certain services, and often a lot of the services are grant based. There's a saying somebody told me when I started working in homelessness was that vulnerable people attract vulnerable services. And it's never left me because it's just so true, that there might be a 1-year grant for something. And then it's gone, and the team are fighting to try and get this thing evaluated quickly to then get it refunded, for another year. So it really is tough to answer your question, Priya. And we need more commitment, I think, from all of us that things are basic rights, like housing it's a human right. To live in safety is a human right. And I think until we really embrace that as communities, and start to all come together and just basically say this is not acceptable. We have to be doing more about this, about the housing crisis, about the epidemics of violence and everything else that we have, to make sure that there is more equality. It probably will continue. So yeah, you're right. It's a whole of society issue, and I guess that's the best way to sum it up. And that's what I understand you were saying there, Priya, is that it's not just one service that's responsible, it's all of us. And there are things that all of us can do. Thanks, good question.
Thank you very much, Jane. And I would like to take this opportunity to, as we are closing the symposium, I want to sincerely thank all speakers, presenters for every single presentation and all the initiatives that you're already being involved in and sharing with us today in this symposium. It's such valuable insights that we have gleaned from just these 2 hours. And a special, I have no words actually, because I'm really impressed and also feel humbled by, when I realize the position that we are in, the place that we are in as a health professional, as a nurse, how much influence can we actually make in this world. And yeah, even a little bit would go a long way is a message, I guess, drawing from all these presentations today. And a special thanks to Nasif as well, who has taken the effort to join us all the way from Bangladesh. And special thanks to Thank you,
honor to
Naseef.
me. Thank
To
you.
Dr. Natalie Cutler and Dr. Albi Sharp for facilitating this open forum. And to all our participants, thank you for joining us and contributing to this meaningful dialogue on advancing equitable healthcare practices and addressing social determinants of health. And your engagement has certainly enriched our discussions today. And this just highlights the collective power of our shared commitment to change. And thank you all once again, and have a wonderful day, beautiful weekend.
Thank you, Priya. Thank you, everybody.
you.
So lovely
Thank
to meet
you.
you. Bye
Bye.
bye.
Thanks, everyone. Thank
Bye-bye.
you.
Thank you.
Okay, we did it. I think we've lost Natalie already. I think she probably had to
We've lost Natalie.
rush off and see her new grandchild again.
Oh, has a daughter delivered already?
Yes, so she was induced. Oh, no, not induced. I think she had was she induced or did she have a C-section? I'm trying to remember. I think a Tuesday.
Okay,
It was. So, yeah.
that's nice.
Yeah, so she has a new grandson.
Oh,
Oh, nice.
Yeah.
Christmas baby.
Yes, absolutely.
Yeah.
Yeah.
Oh, nice.
Thanks a lot, Samandika
Yes,
and Albi.
You
And
know,
between, I
no
got
problem.
a little bit confused with the timing when I
No
shouldn't have.
worries. I was trying to contact you. I couldn't. Oh, have we stopped the recording?
Oh no, that's a good point.